Okay, our next topic is going to be tuberculosis, and we're going to be looking for TB as our answer and when the stem of the question talks about specific risk groups. And these risk groups include immigrants, which they love, immunocompromised patients such as HIV patients, homeless patients, prisoners, alcoholics, any type of immunocompromised patients, okay? And these patients are going to have a pathognomonic presentation with fever, cough, oftentimes with hemoptysis. They'll have weight loss as well as night sweats. Now, if a patient comes in with night sweats, the differential is pretty small, right? Because we know only a few things can cause night sweats, Hodgkin's being one of them, acute HIV. So we're going to look at the stem of the question, we're going to look at the risk factors and the presentation, and then we're going to deduce down to a suspicion of tuberculosis. So if we're suspecting tuberculosis when the patient presents with these symptoms, our best initial test is going to be a chest x-ray. And if on the chest x-ray it is compatible with TB, our next step is going to be a sputum and culture. Sputum culture is also our gold standard for the diagnosis of tuberculosis. But one thing I want you to remember, it takes up to 6 weeks for the results to come back for the sputum and culture. So if you have a patient that has cavitary lesions on their chest x-ray plus symptoms, you go straight to drugs. Okay, you don't wait for the results of the sputum culture before you put them on drugs if they have cavitary lesions plus symptoms. Now, the sputum microscopy for AFB, acid-fast bacilli, can actually serve as a surrogate marker for infectivity. Remember that 3 negative smears means the patient is non-infectious. So it takes 3 negative smears before we can actually say this patient is non-infective. Now, once we do the sputum and culture, if the patients have a positive result, we have to start them on a 4-drug regimen therapy. The reason we do this is because TB is oftentimes resistant to single drug therapy, so we have to give them a 4-drug therapy, okay? And that includes INH, and we remember that INH, we have to give them B6 because side effect of INH is what? It's a peripheral neuropathy, right? The second drug we give is rifampin. We also give pyrazinamide and ethambutol. So what we're going to do is we're going to give INH and rifampin for 6 months, and we're going to start them on pyrazinamide and ethambutol also, but after 2 months we're going to stop the pyrazinamide and ethambutol, and we're going to keep them on INH and rifampin for another 4 months. So INH and rifampin for 6 months, and pyrazinamide and ethambutol we're going to stop after 2 months. You got to make sure when we're giving these drugs, since oftentimes it's homeless people, it's alcoholics, it's patients that may not be compliant. If there is a suspicion or a high degree of non-compliance, you have to give the treatment under direct observation. They come into your clinic, they come into the hospital, and they take the pills in front of you. For TB meningitis, I want you to remember that you have to extend the therapy for 12 months. And in pregnant women, you do not give pyrazinamide, except in one condition, and that is multi-drug resistant tuberculosis. So remember, TB meningitis, 12 months therapy. Pregnant women, do not use pyrazinamide unless it's multi-drug resistant tuberculosis. So usually we're going to treat these patients for 2 weeks, and the patient's going to no longer be infectious. And if they ask what is our surrogate marker for infectivity, it's going to be our sputum microscopy for AFB. And remember, it's going to take us 3 negative smears before we can say they're non-infectious. So that's how we work it up if they have positive results. If we did the sputum after the chest x-ray, of course, and TB has not been established from the sputum, we're going to do a fiber optic bronchoscopy, and this can actually be done to obtain a tissue specimen. So we did a chest x-ray, we did a sputum and culture, and we still can't see the TB, but we have a high degree of suspicion. We're going to do a fiber optic bronchoscopy. We're going to take a tissue specimen. Now, we said our best initial test when we're suspecting TB is chest x-ray, right? What if the chest x-ray is normal? If the chest x-ray is normal, this can be a latent TB. So if the PPD was positive and the patient had a chest x-ray that's normal, this is the latent TB, and what we're going to do is we're going to give INH for 6 to 9 months in these patients. INH can cause a peripheral neuropathy as a side effect, so you remember you have to give B6 pyridoxine as an adjunct with the INH. It does not matter if the patient had BCG in the past. Patients must still take INH if they're PPD positive. This is an important point to know, okay? If the patient is resistant to INH when we're giving them prophylaxis, we're going to give them rifampin for prophylaxis instead, and rifampin is going to be given for 4 months. And if it happens to be a multi-drug resistant TB, we're going to add pyrazinamide and ethambutol. Remember, when we give INH, we have to get LFTs because LFTs can be elevated. And if the LFTs, as a side effect, get elevated up to 2 to 3 times normal, we're going to stop the INH. And remember, once we have finished the 6 to 9 month course of INH, we are going to repeat the tuberculin test. But even if the tuberculin test is positive, we're not going to put them back on INH. We're just going to reassure the patient. So what do we want to know about the PPD? PPD is going to be a skin test, and it's going to be an intradermal injection given in the form of the skin. And we're going to assess this diameter of induration at 48 to 72 hours after injection. And remember, for low-risk adults without any recent exposure, you're going to need 15 mm of induration to consider it a positive test. If the patient is high risk, such as immigrants, IV drug abusers, healthcare workers, institutionalized people, things like this, we're going to need an mm of 10 mm to be a positive test. And if it's an immunocompromised patient or someone with close contact to someone with active disease, or if the patient had a chest x-ray that showed they had prior TB, in these patients, you're going to need 5 mm in order to be considered a positive PPD. And at that point, we're going to work them up as we just said right now. And you want to remember, you never repeat the PPD test that is positive because it can actually cause necrosis. So a couple of things I want you to remember. Remember, if the patient's not compliant, you want to directly observe their therapy. You watch out for liver dysfunction on patients on therapy. We want to give pyridoxine for patients on INH, and we want to watch out for signs of deficiency. And remember, any multi-drug resistant TB is going to require a 5th drug, usually ethambutol. And this is pretty much your workup of tuberculosis, okay? And I hope you guys enjoy it.